Recording is in progress. As you all heard, we got it. And let's hope that those that are unable to join, we will have this session recorded, and we can send if they will request that, and we will if Shin, you can put that in the chat and express that we can share it as needed. My name is Lucica Ditiu. I am the executive director of the Stop TB Partnership, and I am extremely grateful for the fact that we have an amazing group of speakers and panelists in front of us. And also, I am very grateful for all of you that took time to be with us here today. The session will go over 2 hours. We will have time for questions and answers. And we have, as you can see on the screen, amazing individuals sharing their thoughts, sharing their experience, sharing their knowledge with all of us here today. The meeting is taking place in the context of the Tokyo Nutrition Summit. I want to thank the Japanese government for taking upfront and immediately topics that are extremely important for the health and for the agenda currently. And we are very grateful as Stop TB Partnership for an amazing collaboration and interaction with the Japanese government, especially colleagues from Ministry of Health. And I'm happy we are joined today by Dr. Hajime Inoue, the Assistant Minister from the Ministry of Health, Labor and Welfare in Japan. He will share with us a few thoughts at the end. And I will introduce the speakers for the part that I will be in charge as time is going, because they are all absolutely amazing. I want to start by saying that we sometimes are afraid of things. And for a long time, I think a lot of people in the world are afraid now of COVID. And I think we are also still afraid of TB, of drug-resistant TB or extreme drug-resistant TB, even though that is a disease for thousands of years. And a woman many years ago called Marie Curie, she was saying that nothing in life should be feared, and it must just be understood. And it is time to understand more so that we may fear less. And she said that so many years ago, and it still applies so well today. And today we are here, and it's why I consider this as such an important topic. Is because we are understanding more about tuberculosis, and the things that we are now faced with are changing all the time. And we are here to discuss the role of malnutrition and nutrition, and ultimately diabetes and other nutrition-related diseases with TB. And for those of us being in the TB business for so long, we know that we are for so long running after the TB HIV co-infection. I grew up, let's say, my professional career in discussing TB HIV, and we wrestled with the TB HIV co-infection so many years that we arrived now at a level in which is not comfortable, but the TB HIV co-infection is accountable for kind of 10–11% of all people with TB in the world. And HIV became a chronic disease. Unfortunately, TB still kills 1 in 3 people living with HIV. And but what I want to say is that we did a lot of progress understanding what's happened. This is not a session about TB HIV. This is a session about malnutrition and nutrition and implications, because we are learning that actually 20% of people with TB are, are there due to the lack of proper nutrition. 20%. It's a huge number. You deal with this in a proper way, you reduce the burden, and you reduce as well the what you have to deal with and what you have to understand more. So the more we understand, the more we will fear. And I think we all want to hear from everyone here, but from the experts, in terms of the links between nutrition and tuberculosis. What can we do about this? We are 2022 already. And I think all our lives we heard about nutrition and TB. I grew up in a country, Romania, with a lot of TB. People were saying, eat well, eat egg, eat chicken, make sure you have vegetables, and you will not get TB. And I don't think there were data. It was just what's coming through a generation and generations as a way to protect against TB. Now we have data, now we have knowledge, now we have science. And in a life in which, unfortunately, a lot of misinformation and a lot of crazy statements on social media, in a world in which a lot of people are becoming overnight experts, it has to be with us, the ones that know health and global health and have expertise, to really understand and discuss. And ultimately, I'm looking here at Teresa, set the norms and the guidelines to really push the agenda for ending TB together. So so that's why this session is so important. It's a beginning of a road. It's not, it will happen one meeting and then we disappear. We have to continue on this conversation. It is my great pleasure to share with you that we will start with two technical presentations made by two amazing individuals, and I would dare to say friends. Professor Bhargava from the Medical College Mangalore, Yenepoya, and Mr. John Paul Dongo. He is the director of the Union Uganda office. They will each speak around undernutrition and TB, and diabetes and TB, including bidirectional approaches, respectively. In an era in which COVID is really beating us, and politicians understanding very little, taking decisions as they seem fit, not necessary for health, but their own political agenda, understanding what we can do collectively to ensure that not only COVID remains relevant on the agenda, but TB, which is usually a forgotten topic, but funding for TB, which is a topic almost neglected, but as well ensuring that individuals are, that we all understand individuals are not having just TB, and then we don't push them around the healthcare sector when there are other associated comorbidities. And how can we do this together? I think it's extremely, extremely important as a topic. So without further ado, and being very good in time, I actually want to go to you, Professor Bhargava, to start your presentation on undernutrition and TB. And thank you, sir, for being with us and taking time from your busy agenda. Thank you.
Thank you very much, Dr. Titiu, for that introduction and the opportunity. Greetings to one and all who have joined this webinar. And it's my, again, I thank the organizers for giving me this opportunity to discuss the links, close and intimate links between TB and undernutrition, which I believe is an ethical and a scientific imperative to address at this stage of the epidemic. I'll just take maybe a half a minute to just put on the slideshow.
Yes, of course, no problem. Go ahead.
Is the slide visible? And
No, we can see you very well with an amazing background, but not the slides.
I hope they have come up now.
Yes, sir. Clear. Yes.
Yes.
Thank you.
So I will, next slide, please. This slide is the journey of an 18-year-old tribal boy living in eastern part of India, and one of the participants in our field trial, which is ongoing, and the questions that it raises. This boy, it is not only to show the dramatic transformation of a boy weighing only 26 kgs at 18 years of age, with a BMI at baseline of 10.7, gaining about 16 kgs under the influence of effective therapy and nutritional support provided in this trial, but also to highlight some other issues. Our trial intervention is of food baskets and multivitamins, and the primary hypothesis is whether improving nutrition status of household contacts of infectious patients can reduce TB incidence in them, and whether providing nutritional support to patients, actually in both arms of the trial, can improve their treatment outcomes. The questions it raises is, this is an 18-year-old boy in a country with a life expectancy of 68 years. We know from nutrition science that any body mass index less than 13 can be fatal to a male person. And this boy was in danger of losing 50 potential years of his life. He is not an exception in our trial, and our trial data shows that 1 in every 2 patients in our trial has a body mass index of less than 16, which is severe undernutrition. And when in every 4 adult patients has a weight of less than 35 kgs. We have data from other parts of India, which we published, and from the national program, which also makes clear that this is not unrepresentative. But the question it raises is, what is the prevalence of undernutrition and severe undernutrition in patients and programs across the world? We simply do not know, because heights are not being recorded as a routine in TB programs, despite a WHO guideline. And in the absence of height, the accurate estimation of body mass index is not possible. So this is, I think, the whole undernutrition situation is invisible, so to say. The second aspect is, what are we doing in our programs to address the problems of the person in this photograph? Now, the WHO in 2013 released a guideline on nutritional care and support in TB patients, which said that because of the bidirectional relationship of TB and undernutrition, nutritional assessment, counseling, and management are to be considered integral components of TB care. And also that all patients with TB, as with all other patients, should have access to an adequate diet, both in macronutrients and micronutrients. However, the Cochrane review in 2016 concluded, on the basis of very, very limited small underpowered studies, that there is not enough evidence of the impact of nutritional supplementation on treatment outcomes. But it begs the question whether it is ethical even to randomize a patient with a BMI like this to a control arm to gather more evidence. Finally, 1 in every 3 individuals in the contacts has a BMI of less than 18.5 in this population. So can we really reduce TB incidence with such a high prevalence of a risk factor? I urge all of you to just read our protocol of our trial, which was published in BMJ Open for more details. Our collaborators are NIT Chennai and the National TB Program, and this trial is funded by the Indian Council of Medical Research. So the links between TB and undernutrition were very, very well appreciated in the pre-chemotherapy era. And this slide shows, quotations from important publications from the 1900s, then later mid-20th century, on how nutrition could be an important part of prevention and therapy of patients with TB. And Dr. McDougall was actually the first medical officer for TB in the WHO. There was a very influential monograph by Dr. Scrimshaw and colleague, which showed the interaction, the entire evidence of the interactions between nutrition and infection, and TB was extensively quoted in this monograph. However, not much research was done after that. This is a key slide which shows how, which is important to understand, how we have the pathway of development of TB from exposure to infection, disease, and then outcomes. And here the key thing is the transition between infection and disease and the outcomes when a person develops a disease. TB infection only occasionally leads to TB disease. And preventing this transition from TB infection to disease is a well-functioning immune system, which is affected by the state of nutrition and by other comorbidities like HIV and diabetes. When the person develops a disease, again, the state of the immune system is also an important parameter affecting outcome, because disease severity is dependent on the immune status and, of course, the level of TB care. So in the present context, when we don't have an effective vaccine, our interventions can be focused on reducing the transition from TB infection to disease by ensuring that everybody has a well-functioning immune system, and by evolving a more comprehensive and effective patient-centered care model, which will also address comorbidities more effectively, like undernutrition and diabetes. This is just a slide which shows that actually undernutrition in community level is a major driver of TB incidence, because it is the most common cause of immunodeficiency globally. This has been called as nutritionally acquired immunodeficiency syndrome. and it is widely prevalent and it's modifiable. Also in patients, this is a risk factor consistently for TB mortality, and again, which is widely prevalent, easily identifiable just by a weighing machine and a stadiometer, and it is again easily treatable, much more than other comorbidities. There is a lot of accumulating information now on the association of undernutrition, not only with mortality, but for other adverse outcomes which are seen in TB patients, which includes drug-induced hepatotoxicity, delays in sputum conversion, malabsorption of key drugs like rifampicin, and also even after microbiological cure, it is a risk factor for recurrent TB. Also, it has been seen in cohorts with patients with drug-resistant TB that a good baseline weight and an adequate weight gain is a good predictor of treatment success. So even when drugs are not working, this can actually add value. Now, this is unpublished data from the Rations trial showing the nutrition status at baseline of men and women, and you can understand the severity of undernutrition here from this graph, where very, very few people are having a BMI more than 25, and a significant number have a BMI less than 14, and BMIs are going down to less than 10. The weights of the patients seen in this trial are actually very comparable to the national program data from India. Next. So as I said, that there is not enough information out there on what is the nutrition status of patients from country data. And this is an incomplete list and probably non-representative, but we can see that whatever data is available points to a high prevalence of undernutrition in Asian countries, and of course in South Asia in particular, the HIV prevalence is relatively lower. So undernutrition is a major driver of TB incidence in South Asia, which accounts for more than 43% of TB incidence globally. We are in a position to share some of our preliminary results from this trial, given the fact that all 2,800 patients have completed 6 months of therapy. And because we don't have a control arm in this trial, it was considered unethical. We can only compare our mortality figures with historical cohorts, but our overall mortality of 4%, given the fact that this is a very cohort of severely undernourished people, is 1/3 less than findings from a recent cohort in 2018, which had a mortality of about 6%. And importantly, in the group of people with weight less than 30 kgs, the mortality was less than half. So more than 1/3 or up to more than half mortality has been reduced in this cohort compared to historical cohorts. Next. A number of cohort studies which were analyzed in the systematic review published in 2010 showed that there was an inverse and exponential relationship between body mass index and TB incidence. And there's potentially a very powerful impact per unit increase in BMI on TB incidence. Is there any evidence that this can actually work? Yes, the historical evidence of declining TB mortality and TB burden in the Western countries, even before the first vaccine or therapy was discovered, is a pointer to improve living conditions contributing to TB reduction. And McKeown pointed at adequate nutrition as being a key factor in this decline. Recent modeling studies also give a similar picture of that nutrition interventions can be effective in decreasing TB incidence. There are small but dramatic examples, again from the pre-chemotherapy era, on how nutritional interventions can reduce TB incidence. This is from the prisoner of war camp in Germany, where in addition to the poor prison diet, an additional Red Cross ration of 1,000 calories and 30 gram protein led to a more than 90% reduction in incidence in British soldiers compared to their Russian counterparts who lacked access to this ration. And we analyzed data from the Papworth village settlement, where a social intervention which emphasized adequate nutrition and better housing led again to a dramatic reduction of TB incidence in household contacts, although it did not reduce TB infection. So I'm proposing that if we are looking still for a vaccine for tuberculosis, we have already a vaccine of adequate balanced food, or the ABF vaccine, which will work very well in settings with poverty and undernutrition. This vaccine is orally active. It is polyvalent. It will impact on mortality due to other diseases, including in children. It is capable of mass production, safe in women, And not only can it have impact on TB incidence, but it is a therapeutic vaccine which can work in patients with TB as well. So any person developing such a vaccine would have been given the Nobel Prize, but this vaccine has been known since the dawn of civilization. Only thing is that the distribution is inequitable of late. So we need to, in the light of the COVID pandemic, our communities need this kind of intervention, and it will be our collective wisdom, science, and ethics which will help us address this. So I've just mentioned that in the NTB strategy, which is a very comprehensive strategy, which has brought to the forefront the role of risk factors and social determinants, we need to discuss undernutrition in each of these pillars. And I will leave this discussion to the panel discussion. It's my really a privilege to acknowledge the field team of Rations Trial, which worked without a day's interruption in the COVID pandemic to ensure the running of the trial. Also to acknowledge the contributions of my colleagues and the institutions mentioned in this slide towards making this work possible. Thank you very much for your attention.
Thank you so much, sir. Really a very good presentation. I think it will generate a lot of discussions. I think we have some colleagues, pointing, having comments in the chat. Very rich presentation, Dr. Bhargava. Of course, as you will be part of the panel, I hope there will be questions and answers. I think in the audience we have people from the TB community, but also people from the nutrition community. So what I hope is a very good cross collaboration between each of them, each of us actually. So it's great that we are perfectly in time. And without going into question and answers, as we will go a bit later, I want to give the floor to Mr. Dongo, the director of the Union Uganda office, to share with us his slides and his knowledge and his speech. Thank you, sir. Please go ahead.
Thank you so much, Lutrika. I hope my slides are visible. And
yes.
apologies to the participants. My video has challenges. But I'm really grateful to, be a part of this very important event, and appreciate the organizers inviting me to share some of the work that the Union Uganda office has implemented some few years back on integration of tuberculosis and diabetes mellitus care into routine care. So I will be sharing some of the work that we did here, and by view of background, we all know that diabetes mellitus is a known risk factor for TB, but also people with TB usually have about 2 to 3 times higher risk of developing TB than people without diabetes. But also during care and within healthcare facilities, people with TB and diabetes mellitus disease normally have a higher risk of death during TB treatment, but also they have a risk of TB relapse after treatment completion. But again, they also have poor glycemic control, and they usually develop DM complications. But also, as mentioned by the previous speaker, they usually take longer to achieve sputum conversion during the intensive phase of treatment. So in 2014, the government of Uganda carried out a cross-sectional survey, and at that time, the prevalence of diabetes mellitus in the general population was found to be about 1.4%. But as we speak today, we believe that this figure has continued to grow over time. But also during that time, there was also known prevalence figures of diabetes mellitus among TB patients. Also at that time, we had not had any particular sort of intervention that was integrating both TB and diabetes mellitus into care. So at the time of developing the project, we based a lot of the concept development and the approach on the union interventions that had been implemented in China and India around 2011 and 2012. Just again to share some of the guidelines that exist, we definitely have two very common guidelines that most of us tend to come across. We have the Collaborative Framework for Care and Control of Tuberculosis and Diabetes. And this was really, again, a collaborative effort between WHO, the Union, Stop TB, and other stakeholders. And then also we have a guide to essential practice that has been put forward by the Union. And this particular one really is used in the management of diabetes mellitus, and tuberculosis. So just to share briefly about the setting and objectives of this particular project, but also the funding. This was a 2-year cross-sectional observation study that was funded by the World Diabetes Foundation between 2016 and 2017. And the objectives of this particular project broadly were two, and one was to carry out routine screening of diabetes mellitus among persons with TB. And then also at the phase of implementation, we wanted to generate evidence for advocacy that we can then use to speak to the national health authorities to support implementing the project, but also being able to scale up what we had done and the recommendations found out through the particular project. So the setting of this particular project, these were 10 public and private health facilities within Kampala, but again, serving very underprivileged communities. And like earlier said, this is a collaboration between the Union, the National TB Program, the Department of Non-Communicable Diseases, and Kampala Capital City Authority. What are some of the interventions that we implemented? One, we did sensitize Minister of Health programs. This was really particularly the National TB Program, but also the Non-Communicable Disease Program on the need for collaboration for TB and DM-related activities. And then we also held a stakeholders workshop. And in this particular workshop, we developed guidelines, SOPs, training manuals, algorithms for routine DM screening among TB persons, with TB. And these were definitely the tools that guided the training of our healthcare workers to be able to conduct DM screening among TB, among persons living with TB. But also we developed an algorithm, and we based our DM confirmation with a fasting blood glucose value of more than 7.0 millimoles per liter. Also during the project, we did supply project sites with glucose testing strips, weighing scales. We also did customize the registers to be able to document both TB and DM related work. And also were able to provide height boards to our healthcare facilities. And finally, we also did review meetings. And during these review meetings, we did provide refreshments as means of motivating our healthcare workers to be a part of these particular meetings. We also carried out capacity building, and this was really two particular interventions. We carried out post-training on-site mentorships by the project team, including the Union, Minister of Health, but also Kampala Capital City Authority. And then along the way, we're also able to establish a referral mechanism between TB and clinics within particular health facilities. What are some of the results that we picked out of this particular project? Within the 10 healthcare facilities that were supported, about 4,500 persons with TB were diagnosed within these healthcare facilities. And out of the 4,400, about 4,000 of them were screened for random blood glucose levels within these healthcare facilities. And for those persons that had a random blood glucose reading of 6.1 millimoles per liter, we did go ahead to carry out a fasting blood glucose value testing. And of these, we were able to screen about 1,000 persons with TB for diabetes mellitus. And out of the 1,000, 92 of them were diagnosed with diabetes mellitus. But out of the 92, about 71% were actually newly diagnosed with diabetes mellitus. And of the 92, we were able to refer all the 88 to DM clinics for routine care. Unfortunately, 4 of the persons with diagnosed with diabetes died shortly after TB registration. So following this particular project, we did find out that the prevalence of diabetes mellitus among screened persons with TB was about 2.3%. So what are some of the lessons that we learned from this particular project? One, we found out that the success of this particular project really based a lot on the close collaboration between key stakeholders and relevant Ministry of Health programs, particularly the National TB Program and the Department of Non-Communicable Diseases. And then we also found out that the initial stakeholder meeting that we held raised good awareness, but also buy-in on the project among the various stakeholders. Then also developing these standard guidelines, SOPs, training materials, and the support supervision also ensured that the project facilities were able to implement according to the set criteria, particularly, of course, screening persons with TB for DM, but also being able to carry out proper documentation and recording within the recording and reporting tools that were given to our health facilities. Then also mentorship visits provided by the project team also ensured that our healthcare facilities were able to maintain the standards, but also in that way, if we found any challenges raised during the course of implementation, these were easily addressed and responded to. Then also the review meetings provided a good platform for assessing progress, but also being able to share some of the lessons within those particular health facilities. And then instead of providing training within a centralized manner, we did carry out training at health facility level. And we think this was also a very good approach to make sure that we captured a bigger number of healthcare workers, but also the healthcare workers felt this also gave them a bit of hands-on knowledge with training at facility level. So some of the challenges, most of the challenges we faced within this particular project were really service-related challenges. And these were, one, there was a really lack of sustainable supply of glucose testing tubes. And of course, this really affected the screening for diabetes within our facilities. But also as a project, we did not have community engagement. So this was also another challenge that we're not able to trace persons who failed to return to the health facilities for fasting blood glucose testing. Then we also had high staff attrition within these healthcare facilities, but also at the start of the project, there was a lack of routine DM services within some of the healthcare facilities. And then also, we also noted a lack of linkage between tertiary hospitals that provide specialized DM services with primary healthcare facilities. So just to go over some of the limitations, the fact that we're not able to provide oral glucose tolerance tests, we think this could also have undermined, but also probably underestimated the screening for DM within our healthcare facilities. Then also too, because the tests were only done at the time of TB registration, it's also possible that because we did not carry out these tests at the end of the TB treatment, maybe we could have also misdiagnosed some of our clients with diabetes. But also we lacked the glycosylated hemoglobin tests that are usually less influenced by infection. And of course, these were mainly because they're not usually available within our health facilities. So this could also have probably hindered some of the accuracy of our results. In summary and conclusion, based on this particular project, we found out that the prevalence of diabetes mellitus in persons with TB is, of course, higher than the general population in Uganda. But also, we also realized that screening of persons with TB for DM in routine program setting is actually very feasible in places like Uganda, where the TB epidemic is very high. So we're also able to publish our results, as you could see there. I'd like to acknowledge all the people that were part of this project. Thank you for listening.
Thank you so much. This is really great, and I think it will be a great moment of with the question and answers, because there are a lot of information is shared in the chat from Myanmar. Thank you, Ikushi. I see now from Nigeria, and there are, I imagine, a few others above. Our colleague Patrick as well. Thank you, and Srinivas. So thank you for the comments. And there is a question also from Mr. Yoshida. My role now ends with the thank of our two amazing speakers to start the discussion, and a very cool panel, equally amazing, is following. And I want to give the floor to my colleague Sahu Suvanand, the Deputy Executive Director of the Stop TB Partnership, to take it over from here and continue with the panel. Thank you.
Thank you, Luchika, and thank you to the two speakers. Excellent. You nailed those two topics there, undernutrition and diabetes and the relations to TB. We now have a very amazing, distinguished panel. The format of the meeting from now on will not have slides, promise you that. It will be discussion, and I see that people have already started writing things in the chat, which is excellent. We will have some time at the end of this panel before we conclude to take questions also live, if that is possible, during this session. So let me start first introducing the panel. We have people coming from very diverse perspective. We have here Teresa Kazaeva, who is the director of the Global TB Program in WHO in Geneva. We have our second panelist as Ingrid Schoeman, Director of Advocacy and Strategy for an organization called TB Proof in South Africa. She is also someone who has survived TB and the impact of undernutrition. So it would be great to hear from you, Ingrid. Our third panel is panel member is Michael Smith. Michael Smith is HIV advisor and UNAIDS focal point in World Food Program, organization that works on nutrition. So he will be on our panel. Then our next panelist is Eliud Wandwalo. Eliud is head of tuberculosis in the Global Fund in Geneva. We will also have Anurag Bhargava and John Paul Dongo to also join us in the panel. So let me first start. So I will open up with a general question, and then I will ask the panelists all some questions on next steps, and then we will take questions from the audience. So let me first start with Teresa. So Teresa, you are head of the WHO Global TB Program. WHO sets the norms, policies for both TB as well as nutrition. So tell us about your perspective about TB and nutrition.
Thank you very much, Sahu. First of all, I would like to start with thanks to Stop TB Partnership Luchika did use SAHU and the government of Japan for the organization of this extremely important webinar. And I am really pleased to join well-known experts and high-level professionals and colleagues at this panel. Yes, it's very timely discussion, and unfortunately, based on our latest global TB report, we can see that for the first time over the decade, TB deaths are growing, and it's a very concerning trend. And of course, the main reason is the impact of COVID-19 and disruption of the essential TB services. But unfortunately, based on our modeling, we are further predicting growth in 2021-2022 of TB-related deaths and TB incidence unless urgent measures will be undertaken. And further, this worsening of the situation will be driven, in addition to these essential service related issues, also to the social economic impact. And we can see it already because TB is a clear example of this disease driven by social determinants heavily. And these growing rates of poverty and undernutrition will definitely influence and are already influencing on the global and the country situation with tuberculosis. Yes, it's well known, these linkages between TB and top 5 social determinants: undernutrition, diabetes, HIV, poverty, smoking, and alcohol use. And we have all the evidence data showing and proving it. And I would like to refer you to the global TB report where you can find this. And because we're today talking about undernutrition, almost 20% of the global TB related incidents are due to undernutrition. And evidence clearly shows that there could not be double opinions. And it's well known. And our colleagues, expert Dr. Bhargava, clearly presented that evidence from the latest trials and studies that undernutrition is not only risk factor, but also significantly malnutrition, worsening treatment outcomes, increase TB-related death if it will not be addressed appropriately. Data are there, linkages are there, and I must say that in the anti-TB strategy, again, as it was presented, Pillar 1 clearly shows that the best approach should be integrated, patient-centered TB care and prevention. And that principle is there, as well as many other principles, but the reality is different. We have even guidelines. We are on a regular basis updating them. Our guidelines were dated to 2013, and so I will maybe a little bit later share our further plans. We have also guidelines from 2019 developed by our the department or the WHO, another department on nutrition, which includes also TB-specific recommendations that it should become essential part of care, including for younger children. So. As I told, we have evidence, we have guidelines. Now we have new tools as a multi-sectoral accountability framework, and social protection nutrition support is a part of this framework, as well as I would like to refer to top 10 recommendations of the 2020 UNSG report, where they're also highlighting importance of the nutrition support. I remember from my personal experience when I was at the early ages of my professional career as a doctor, one of the basic principles shared with me by old physiologists in Russia were, before putting on treatment, you should provide nutrition support to your patients, and this is fundamental. I would like also to bring another example from the history. After the Second World War, one of the first decrees released by the Russian government in 1 month after the end of the World War decree to provide nutrition support for patients with tuberculosis. And you can imagine that at that time there were a lot of issues. Country was in ruins, but there were level of understanding that nutrition support for people with TB is absolutely essential to avoid outbreaks and stop development of the pandemic in the country. So we should come back to this level of understanding. As WHO will continue doing our best, and I'm using this opportunity requesting Dr. Bhargava and other colleagues share with us all the data. Of course, we will use it, we will update all our guidelines on regular basis, but guidelines themselves without uptake are not providing treatment. And I think that it's absolutely critical. And final thing I would like to highlight that why, again, when we are talking about other communicable diseases like HIV and malaria, we are considering measures, prevention measures, and like the distribution of anti-mosquito nets, reagents, other measures in HIV programs like procurement of condoms as essential members. But in TB case, we are not considering nutrition support as absolutely essential measures. So we should unanimously come to this point once again and highlight that TB is a very complex disease. And without comprehensive and broader measures, we will not be able, especially in the current situation, address it effectively. Thank you.
Thank you, Teresa, for talking about the WHO guidelines, also from your personal experience. You reminded us of post-World War II situation and how people used to rely on nutrition before the antibiotics were scaled up. And also this issue about nutrition being essential to the TB response. So now I move to Ingrid. Ingrid, you have lived with the experience of TB and also you know what has been your status of nutrition. And so tell us your perspective about TB and nutrition, and especially, focusing on your learnings from that experience.
Hello, everyone. We are really grateful for this meeting by Stop TB Partnership advocating for increased nutritional support for people affected by TB. So in 2012, TB nearly killed me. I was working as a dietitian in public hospitals in South Africa, and I thoroughly enjoyed my job. But then I became very sick and I was admitted to ICU. The doctor diagnosed me with XDR TB through a lung biopsy, and I was moved into this isolation room. And they started me on TB treatment, but the treatment side effects were so toxic that I developed liver failure and I went into a coma. I deteriorated very quickly, and the doctor phoned my family from Pretoria to get on the next flight to come and say goodbye to me. Fortunately, after a couple of days, I woke up from the coma. But my entire world had changed. I went from being a dietitian to being a patient, and from being free to completely bedridden. I had lost 30% of my body weight, and my stomach was so swollen from the liver failure that I was unable to eat despite having an abdominal tap to drain some of the fluid. So the doctor inserted a nasogastric tube in my nose to feed me through it. I was vomiting, I was having diarrhea every day. I was so weak I couldn't sit up in a bed, and I really hated being bedridden. It was a horrible experience. In fact, I didn't recognize this person who I had become. And I was in hospital for 75 days, of which over a month was in ICU. I really received excellent clinical care and kindness from the health workers. My friends and family visited and supported me. I had job security, I didn't have financial stress, yet I wanted to give up. I felt completely overwhelmed. This experience was very hard and it gave me a bit of a better understanding what the majority of people in South Africa who don't even have food on the table to eat are going through. And to be honest with you, I don't think I would have survived had I also been faced with malnutrition, food insecurity, or hunger. Studies in South Africa found that about half of patients were malnourished and also suffered from anemia or low albumin, low hemoglobin. And micronutrient deficiencies like vitamin A increases your risk for developing TB. Food insecurity in KwaZulu-Natal province in South Africa was 3 times higher for people with drug-resistant TB than for the general population. And people with drug-resistant TB in South Africa do qualify for nutritional supplementation. However, amidst COVID-19, these applications for social support grants were totally impaired, leaving people hungry and often hopeless. We heard from Dr. Kaseva that TB deaths increased, and in South Africa last year we lost 61,000 people, an immense and unacceptable human cost caused by a curable and preventable disease. Looking at national strategic plan targets to eliminate poverty and reduce inequality, this will not be achieved if the poorest 40% of our population continues to carry 65% of the TB burden. Therefore, political commitment is now needed to prevent malnutrition. We need to assess people's nutritional status and refer them for nutritional support. And we need to take into account that these people have no other food often in the house or an income to buy food. So even nutritional supplements that are provided have to be shared between household members. And therefore, food parcels are not enough. Each person should receive high quality TB care free from stigma and discrimination. And part of this package includes adequate counseling to help people overcome other challenges such as stigma faced, for example, when people lose weight and worry about being gossiped about because their physical appearance had changed and there's this association with HIV that people fear. As a communication expert recently explained to me, we need to talk about things that matter to each individual instead of these blanket approaches that do not fit their needs, their worries, or their concerns. And community health workers provide this care and support at household level where they are known and trusted. But they also need to be supported. So there's a need from the government to train community health workers adequately, give them PPE and infection control equipment, and also to give adequate remuneration. We have an opportunity to leverage the COVID-19 response to strengthen the TB response, and TB recovery plans need to be implemented urgently. Each time we speak about COVID, let us also raise awareness about TB, as both are airborne diseases, to give people hope that TB is preventable, curable, and can happen to everyone. Thank you.
Sorry, I was muted. Thank you, Ingrid. Thank you for sharing your story, but also the work that you are doing, in South Africa on advocacy from these learnings that you had in your personal life. So thank you for that. Now we go to Michael Smith. Michael, from your perspective and the perspective of World Food Program, tell us about TB and nutrition.
Sure, yeah, thanks so much, Sahu, and I just want to thank everyone involved with our partners at N4G for putting this on. And yeah, so I'll just speak a little bit about this from a WFP perspective, and really I'm still kind of gathering myself from Ingrid's intervention, where I don't think she could have sort of set me up any better, but I think it's also very useful way to have a sobering understanding of what people living with TB are still dealing with, and that there is in my opinion, totally unacceptable failure to support the whole person and not just treat the disease of TB, to help people meet their essential needs, to help them cope with risks and shocks. And that for me is really what WFP's role in a global TB response is all about, is one, kind of understanding the crucial element of food security and nutrition. And I think harnessing some of the platforms and some of the tools that WFP have at its disposal, and working very closely with key partners at WHO and others to really have a multi-sectoral, multi-stakeholder approach. And I think, you know, the first part of my intervention was going to be around kind of the basics of food security and malnutrition and TB. And I think our technical presentations at the beginning of this session really hammered this home. And Teresa highlighted very well that undernutrition, time and time again, in all of the 30 high TB context countries, undernutrition is a leading factor there. And frankly, the presentation I normally make is all about this kind of positioning, and I'm getting tired of doing it, because the peer-reviewed evidence is there, the anecdotal evidence is there, the evidence from partners is there. It's becoming a really old story. And I don't know if we're not saying it the right way, if we're not saying it loud enough, that making people food secure and addressing malnutrition are things that we can do well and we know how to do. And we're just not doing it. And I think it's yeah, just really unfortunate. So, you know, from WFP's perspective, you know, the work that we do to support the most vulnerable and people living with TB isn't really rocket science. You know, I kind of want to say it's nothing really special. We kind of take a two-pronged approach, and we focus on addressing and supporting the individual client, and that's usually through nutrition support. And we provide a lot of mitigation and safety net support to households because, you know, as I said earlier, it's not really just about dealing with TB itself as a disease, but it's about supporting the household, and the fact that a lot of people have lost livelihoods, they've lost incomes, they're food insecure, they're making the choice between having to eat and go to a medical appointment. That's totally unacceptable in my opinion. So we take a two-pronged approach where we really try to kind of get a handle on the malnutrition status of the client first and foremost, and provide them with nutrition support, counseling support, and other follow-up services to, one, kind of get them healthy, because we know that food security and nutrition are prerequisites to a healthy and full life. And then that other support around the household, and that a lot of times is in the form of in-kind transfers, cash-based transfers, voucher support, where you're trying to mitigate and kind of soften and mollify the impacts of disease from that social and economic perspective. And we've found that in the last 2 years, our programming on TB and of course on HIV has really taken a very sharp focus on this socio and economic support because of the COVID situation. And so now we're dealing in a context and a reality where people aren't just dealing with TB, they're not just dealing with HIV. We're in a syndemic world. You're living with COVID. A lot of the presentations earlier talked about other comorbidities around diabetes. People are suffering from mental health, you know, difficulties. So the approach and the support really needs to be structured from a people-centered perspective. And these kind of layered health challenges that people are dealing with are kind of, you know, stacking on top of each other, and they're compounding. So, you know, giving treatment for TB really is just one part of the solution. You really need to be providing support to the entire individual and to the family. And so that's kind of one huge element, obviously, of what we do tackling TB. I think the other side that needs to be discussed is kind of the technical, political, and governmental influence that could be leveraged, especially by UN agencies. And that focuses a lot on providing technical support to governments to help them revise national policies and plans, leveraging a lot of the existing tools that WFP already has at its disposal around rapid assessments and vulnerability assessments, because then you can bring those reports to key stakeholders and say, actually, your programs aren't adequate. Your social protection platforms need to be expanded. They need to be adapted. You need to expand vertically. You need to expand horizontally. You need to have that evidence and that technical expertise to really show key stakeholders that more needs to be done. And I think a key follow-up and a key action that WFP has been quite successful in is revising those national policies and strategies around nutrition and around TB, and kind of pass those policy platforms back to the national level, because that's where you're going to have the most kind of bang for your buck. That's where you're going to have the reliability and the confidence of the government to provide those support services to the people that are most vulnerable. So, you know, in summary, it's a drum that we keep beating, unfortunately, and we continually have to remind people how crucial food security and nutrition are. But we have a lot of tools, and we have a lot of platforms, and we have a lot of solutions. I think we need to be better about articulating what we can do individually. And of course, we need to be harnessing those skills and expertise collectively, again, for kind of a truly multi-stakeholder, multi-sectoral response that really is looking at the global TB response beyond just treating the disease, but supporting the entire individual and household. Thank you.
Thank you, Michael, for that perspective, multi-stakeholder, multi-sectoral approach. And this whole thing that this is not a rocket science, this is something that has been known for a long time, and we must act now. So let me go to Eliud Wandwalo. Eliud is from Global Fund. Global Fund, as you know, is the main external donor for TB in Global Fund eligible countries, basically low and middle income countries. So Eliud, what is your perspective on TB and nutrition? We can't hear you, Eliud. Eliud, we can't hear you. Is that everybody or just me? Yeah, go ahead now.
I think it's everybody, because I cannot hear Eliud either. Yeah, maybe you connect.
So Eliud, maybe you can disconnect and connect again so that we can get your audio there. We are not able to hear your audio, so sorry for that. Meanwhile, we will proceed to the other panelists, and we will come back to you when you reconnect. I also request Mohammed and Shin to see if there is any technical problem. Okay, so we will now go back to Anurag Bhargava. You presented very convincingly data from your project and your work linking TB to nutrition, and also this whole aspect of nutrition, to think about it like a vaccine for TB in these times when everybody is worried about vaccine for COVID. That's very interesting concept. Now, if you have to go forward, tell us about what are the next steps that you would recommend that taken to address nutrition. And so, Eliud, if we can come back to you, I'm asking a question to Anurag, and then we will come back to you. Just
okay, that's fine.
Good, we can hear you. So, Dr. Anurag Bhargava, please go ahead.
So, thank you again for this opportunity, Dr. Sahu. So, as I mentioned in my last slide, first of all, as a global leader in TB discourse, the WHO has come up with this comprehensive NTB strategy, which for the first time has introduced words in the TB lexicon which were not missing from earlier strategies. Talk of patient-centered care, which is responsive to patients' values and expectations and needs. There's talk of bold policies and actions on social determinants, which are driving TB incidence. So I would just say that, and third is of relevant research to facilitate implementation of strategy. So the first pillar is integrated patient-centered care, and the data from India actually shows very clearly that we are having unacceptable levels and severity of undernutrition in our patients, which is contributing to mortality. And I would again emphasize this, that much of the mortality in TB patients in India and across the world is in the early phase, before 2 months, before really even the TB therapy has taken effect. And many of the side effects are also occurring in the first 2 months. So in that phase, actually, we are facing patients who are dying early, and it is clearly linked to their body mass index and their performance status. Both are easily accessible at this thing. So we would suggest that the WHO recommendation for assessment of all TB patients, irrespective of drug resistant, drug susceptible, extrapulmonary, pulmonary, has to be done so that there is a risk stratification. TB remains the only disease which is a killer disease in which people are not assessed for severity at baseline. And even in COVID, you are assessing, making an assessment of severity at baseline and then doing appropriate triage. In TB, for some reason, we are assessing them for their sputum status. We are looking at HIV and diabetes, comorbidities. But otherwise, it is left to the judgment of people to just send them home when they may not be able in a situation where they will survive this initial few weeks of therapy. So nutritional assessment will help us, identify patients who are particularly ill. And the WHO guidelines says actually in the 2013 document that all patients with BMI less than 16 should be treated according to WHO guidelines for adult malnutrition. Now that WHO guideline is 1999 vintage, and that says that admit all such patients in the hospital for inpatient care. That possibly is a logistical issue for people like India, and we have a more nuanced approach to this. So if there are other issues like, the person has unstable vital signs, very poor performance status, then they should be admitted. So nutritional assessment will help risk stratification also and identify people who are likely to die early. These patients will require, may require inpatient care, may require closer follow-up. And this message has to go out to our field workers that this patient needs this thing more than the routine assessment. The other thing is, as part of this thing, so we have to evolve. Now the WHO 2013 guideline is a very good first step because it first said that in the absence of evidence which may be unethical to gather, we have some guiding principles, and it enunciated those. But now we have to build on this guideline and revise it so that the uncertainty is around, what is the optimal mix of, what is the optimal caloric intake, protein intake, what is the optimal content of a food basket, for example, can be decided. And I believe from our experience that nutrition support has to be graded according to the local context and the clinical situation. So it need not be a one-size-fits-all food basket, but something which is graded according to the patient's clinical condition. For example, the patient that I showed in my slide, even at the end of 6 months, he had gained 16 kgs, but still had a BMI less than 18.5. So probably many of these patients will require some additional support for a few more months. And we should look at it as a form of therapy. The other thing, so the technical component will have to be there, and all our field staff have to be trained in this nutritional assessment tools into the care of patients with severe undernutrition, and the health systems have to be strengthened to take this into account. So that is one next step that I feel. As part of patient-centered care, nutrition support should be considered, as you said, an essential, not an optional component. And we have to operationalize this in our programs. Before we do that, we can do a very quick situation analysis in all our TB programs of what is the prevalence of undernutrition in our patients, what is the prevalence of diabetes, we already know, so that we can contextualize this guideline and not have again a similar guideline in context which is not really applicable. So that can be done very quickly as well. Now, we need the involvement of the nutrition community in these next steps. As people in public health or in tuberculosis, we need people to inform us about the content of these food baskets. One thing I would say is, there was a comment in the chat box as well. The food intervention should be scalable and sustainable and culturally acceptable. So I feel that something which can be decentralized in its procurement and distribution, like a food basket, along with multivitamins, is much more scalable and sustainable than a centralized production of some ready-to-use therapeutic food. So there are trials going on of RUTF also in India in a limited way, but for the larger program, actually, especially in the situation that we are in, food baskets are probably a better, more sustainable and scalable option. So the nutrition community historically has been concentrating on maternal and child nutrition. I think overall there needs to be a change in that focus to adult nutrition, and particularly of men. In fact, we have seen in our trial, there's not really any difference in the weight loss that men and women undergo as a result of TB or the requirements as such. So we need actually some nutritional assessments, nutritional surveillance. We have 5-yearly programs, but I think this should be an annual exercise, particularly in vulnerable populations, of what is happening to nutrition. Because as Dr. Kaseva pointed out, in the era of COVID pandemic and climate change, the food insecurity and worsening undernutrition can really lead to a spike. And we saw that in Zimbabwe in 2008 crisis. Immediately, TB incidents spiked in Zimbabwe. And when measures were taken, also the spike came down. This happened in Cuba in the 1990s also. So there is very robust evidence that we need to respond to the changing situation of food availability and malnutrition in the community, for which we need a nutrition surveillance program, which we can do with the nutrition community as such, and not leave the men and adults out of the whole discourse, because for some reason we don't completely understand. Men are more vulnerable to TB and also suffer higher mortality. So that was my this thing. And TB and nutrition is a vastly under-researched area in all its aspects, clinical aspects. We need to document really these associations, whether they are causal or not between, say, and what can we do to sort of address, for example, higher risk of drug toxicity. So there is a rich area of clinical, operational, and public health research waiting to be done. And this should go concurrently. We should not wait for evidence before we decide our next steps. As Dr. Bradford Hill said, that science is always evolving and evidence is always incomplete. But that does not allow us the liberty of just waiting for evidence to emerge before we take the next step. So on those rounds, I would say that there is a crisis. There is this thing. Patients with TB should take their drugs on an empty stomach, but the stomach should not be empty thereafter. Thank you very much.
Thank you, Anurag. So we will come back to this. I'm sure others will also speak about some of these points. But I was thinking about, when you were talking about nutritional assessment, are there some digital tools or apps that can make people's life easy in a programmatic setting at scale? Maybe we'll come back to you if you have any thoughts on that, but later. Let me go to Eliud, back to Eliud. Sorry, Eliud, we could not hear from you the first time. Please go ahead, the floor is yours.
Hello, can you hear me now?
Yes, very well.
Thanks, thanks. Thank you, Sau and the Stop TB partnership for inviting the Global Fund in this important discussion. Also, thank to the government of Japan for convening this meeting. I would like, just in the interest of time, not to go back into explaining the importance of nutrition, not only for TB, but also for the other 2 diseases we are also tackling here at the Global Fund. So for us at the Global Fund, this has been very important area of support. We have been supporting countries, especially what we call enablers. So most of the countries, they've been requesting the enabler part as part of their funding request. And this has been one of the core components of the TB funding request and support. We did some review some years back, and we saw in that review about 80% of all the TB support goes into the enablers part of it. And most of it go to support nutritional support. Most of this support is requested in the context of improving TB treatment adherence, and also as part of the pro-poor approach, really, as part of the poverty alleviation. And we do that as well also in HIV in the context of AGYW programs, which we are supporting in many countries. When we look at the issue around nutrition support, I think what we found in the most of the funding requests which were submitted to us, many countries prioritize drug-resistant tuberculosis patients as one of the priority group, and also people who are vulnerable and key population, the people who use drugs, for example, pregnant women and children. So those are the main groups which are prioritized for the nutrition support in most of the programs we have been supporting. Most of these programs are run by international NGO or local NGOs. In many countries, this support is provided either directly to the patients through cash transfers or food packages. So those are the kind of the support which we have been seeing. I think some of the challenges we are facing with this aspect of the support, first is really very difficult and challenge to operationalize food support, especially to the patients. This is because of the management and logistics which are required in order to be able to provide this kind of support, and also to be able to monitor this support and ensuring that it reach the targeted group. So this has been one of the challenge we have seen across most of the countries we are supporting. The other challenge has been the sustainability of this type of support. We have seen some few countries where this support was provided, and then later on this support was taken by the government. But in most of the cases, this really relies on our support. And whenever we stop or we don't have any funding for this activity, then I think this activity is no longer sustainable. So that has been one of the challenge on this one. I think in terms of going forward, I think this is an area which needs a little bit of looking in terms of how could we make this activity more sustainable. And here I'm looking at how can we integrate food support, nutritional support to patients as part of the general support or as part of the support through the government system. I think this is one area which is very critical. Whenever we have this kind of component and it goes to our technical review panel, this is the kind of comments which are coming through our review panel. They would like to see really the sustainability of this type of approach. They would like to see the operationalization. And also we have a little bit of challenge in terms of really to be able to document the impact of this kind of support. It's very difficult to be able to get the indicators, the right indicators, to be able to document the impact of this. And I know there have been some few studies which have, shown that the impact, especially when it comes to treatment outcomes, etc., is not very conclusive. So I think this is an area where it needs to be very clear in terms of what is the impact of this. I think the other aspect which I think we need to focus going forward, I think is in terms of education of the patients and also the community in general when it comes to the importance of nutrition. I think this is something which could be done, could be incorporated into our funding approach, where we provide education to the patients on the importance of nutrition, and also to the community if we also want to focus on the risk factors for tuberculosis. I think as part of really providing a comprehensive package for TB patients, I think this needs to be included in the package of care of TB patients. We need really to work with health workers to be able to educate them on the importance of the nutrition, the importance of assessing patients for nutrition status, and be able to link them to the appropriate support mechanism which is available. So I'll stop there and I'll be happy to answer most of your questions. But this is an important area of work for Global Fund. We are now in the process of starting to operationalize our next strategy. And it will be important to be able to highlight this area, but also how the Global Fund could further support this area and making sure that this is part of the package of the TB support. Thanks.
Thank you, Elu, for elaborating how Global Fund supports countries with this. Now, let me go to John Paul Dongo. If you can tell us, you presented very nicely about the link between diabetes and TB and the findings of your work there. What would you recommend as the next steps?
Thank you so much, Zahu, for the very brilliant question. But I think most of my recommendations really, as regards to TB and nutrition, would really go into areas of integrating activities within the healthcare facilities, but also at community level. When you look at most of our healthcare system, we always have a lot of barriers that hinder the continuum of care. So one of the things I would recommend is if we are to be able to integrate these two programs running concurrently, we definitely need to do a lot of work to be able to address some of the service-related barriers that normally hinder nutritional screening and management of patients within the communities, but also being able to improve again the management of both TB and nutrition within these health patients that we relate with. Then secondly, at a level of community, at the level of the community, we know that there are a lot of community-related interventions that do happen, but particularly for the TB program, we do have contact tracing and investigation being done. I think for me, the other recommendation I would make is we should be able to support the integration of household TB contact tracing at community level with nutritional screening and assessment as we we support and help our patients out there in the community. And then thirdly, and I think this has really come across from the different speakers and presentations, I think we need to really foster and support the collaboration of both the TB and nutritional programs as a Minister of Health, but also involving other stakeholders if we're to be able to easily support and promote successful integration of these two interventions, of course, TB and nutrition within the patients we support. And then finally, I think, again, at the level of Minister of Health, there is need to put in place national level guidelines and policies that support and promote the integration of these interventions. And if these interventions are in place, then we should be able to, have the ministry guide then different implementers and stakeholders to be able to, support and implement these two programs concurrently. So those are my few remarks on recommendations that I'll put across for this program. Over.
Thank you, John. Thank you also for stressing that integration part. Now we go back to Teresa. Teresa, your thoughts on the next steps, what should be done?
Thank you, Saho, and thank you, colleagues, for very rich and substantive discussion. I've put a lot of notes, and first of all, as the representative of the leading technical agency, I should reaffirm that we will continue our work on the update of norm standards, guidelines, and policies. And definitely there are questions, research questions on which we should respond and as soon as possible. So, and these commitments will be with us and followed by concrete actions very soon. We have clear plans on the release already this year, new guidelines on social protection for people with the TB, which will include also specific section. We are planning to update based on the latest evidence our guidance for nutrition for people with TB dated by 2013. We are also planning to release guidance and best practices document for the multi-sectoral accountability framework adaptation and implementation. And of course, we would like to encourage you to be actively involved in different studies, operational research activities, and share with us all available data to strengthen our global guidance. But in the same time, I would like to repeat, looking at our the current status with the uptake of recently updated guidelines for TB diagnosis, TB treatment, it's very, very slow. And there are no reasons. We are recommending, based on strong evidence, faster, more effective with new drug, fully oral treatment. What are the reasons of non-uptake? And our diagnostics, the treatment diagnostics coverage with the WHO recommended tests is only 30% among all the bacteriologically confirmed cases. This is our reality, and I will repeat, the guidelines will be there, but we should be all doing the best to provide uptake, and also to elevate these commitments and knowledge to the highest level of the decision makers. At the first ever high-level meeting on TB in 2018, heads of states made very bold commitments and agreed to do the best for people with HIV, but we are far beyond these targets. And one of the requests was to provide adaptation and implementation of multi-sectoral accountability framework, which includes also clear responsibility and accountability different sectors and stakeholders for the TB response. And I think that, and we are monitoring situation, working closely with the World Food Program, other UN agencies at the global level, and also we know that they're working at country level, but this work should be strengthened. We need strong advocacy, and we should hold those decision makers accountable. And the criteria and the examples of our effective measures should be, I think, measured not by the number of guidelines, webinars, and even meetings, though they are very important, but by the concrete measures implemented in the countries related to the social protection packages, cash transfer, food packages, and this we should look all together and try to monitor and report. So this is extremely important, and I can bring you a quick example. When I visited one of the highest burden countries with the highest prevalence of TB and asked the representative of Ministry of Social Protection, so how this vulnerable group of people with TB is reflected in your portfolio, there would be nothing. They were not considered even people with the TB as a vulnerable group, and it means that there were no adequate social protection measures, including nutrition support. So a lot of work in front of us, but we can't give up despite all the challenges, because the situation is really concerning. So let's continue working together. Thank you.
Thank you, Teresa. Thank you for those information about the new guidelines that are in the pipeline, but also reminding us about the UNHLM. The UNHLM 2023 is also coming as an opportunity that we should not miss. We actually did some review of the political declaration of 2018. There are quite a paragraphs which are talking about nutrition and TB. So there is already a commitment there, but we need to see also in 2023 how we take it forward and make it stronger. So let me go to Ingrid. Ingrid, any next steps from your side?
Yeah, just want to echo what you said. So, Teresa, it's really great to hear that the updated social protection guidelines are coming out soon. Other things that we were thinking about is that each country's Minister of Health can call for person-centered mechanisms of action to support local communities to access healthcare and social support. So we've seen for the TB response that we also urgently need to strengthen the health system. So that's including supporting and protecting health workers, but also putting communities first. And we've seen that local community leaders or local TB champions are really key to successful advocacy campaigns. And therefore, dietitians, nutritionists, and health workers need to work closely with these community leaders to implement effective campaigns. It's really time, if we're thinking about nutrition and education, we need to come up with context appropriate messages on nutrition in local. If I can just say a quick example from South Africa, so we learned through working with community health workers that traditional ways of messaging, for instance, me sharing my story as a TB survivor, wasn't really interesting for people. Rather, they wanted lively, participatory theatre plays to share information. And I think if we really want to bring change and bring communities with us, we need to pause and reflect about how important local community leaders are to achieve any of the SDGs or commitments made at the HLM on TB. So providing communities with scientific evidence and accurate information is only useful if it's framed by people's experiences. So we need to rethink how can we couple people's experiences and storytelling to engage communities on these important facts regarding nutrition and TB. I would like to end off with the most important point from my perspective. So inequality is a driving force of poor health, and this needs to be addressed with adequate resources and political prioritization. COVID-19 showed us what could be done to fight a health emergency backed by political will and strong leadership. And now we believe that SDG 2 can be achieved. And civil society wants to work with political leaders to end hunger, achieve food security, and improve nutrition in all our communities.
Thank you, Ingrid. Thank you for that perspective that you talked about, the community first perspective. That is important. And all the rest that you talked about in the next steps. So let me quickly move to Michael. Michael, do you have any next steps to recommend?
Yeah, thanks, Sahu. And I think Teresa and Ingrid covered quite a lot. And during the session, I was looking through quite a few private comments that were directed to me about how, my comments really resonated and how we're still not able to move the needle after all of our efforts, and actually kind of how straightforward our path is. And I think, yeah, the way forward, as Teresa said, is one part, keep doing what we're doing. There's always going to be a case where urgent specialized nutrition supplementation is needed for malnourished clients. I don't think you can move away from the fact that we're operating in a growing number of emergency and humanitarian contexts where there's food insecurity, where there's poverty. There's going to be a need to support the individual. But I think forums like this, working closely with WHO, having this multi-sectoral approach is a very strong way forward. I think another kind of understanding the global TB community needs to confront is the fact, and I think it's quite similar for the global HIV community, that frankly, interest in funding and supporting a single disease outcome is waning financially, politically. We've been shoved into the corner from COVID and kind of relegated to a second tier, and we're having difficulty finding the space and time to influence people that really matter. And both for HIV and TB, we have new political declarations. We have new strategies, new approaches. That's a huge start, and that's a way to show a concerted kind of uniform global response. But for me, I think we also need to be harnessing the platform that COVID has given us, and understanding that one key programmatic and policy area that has more financial and political support than ever before is social protection. Over 3,000 kind of platforms, programs, instruments have been launched on social protection under COVID-19. Spending on social protection is higher than it has ever been since World War II. The World Bank has come out with, I don't know, it must be 19, 20 different versions of a living paper on social protection platforms that have been developed and rolled out and changed during COVID-19 as a result of COVID-19. I think our response in working with our key partners needs to be focused on reaching across the aisle and speaking the language of social protection practitioners and making it the social protection sector's interest to support TB, HIV, and health in general, because I think that's where you're really going to get momentum. And it goes back to this point that a lot of my fellow panelists have talked about, is the need to inform and revise and validate national plans and policies, working closely with national actors, ministers of health, because that's where you're really going to be getting long-term and sustainable support, as Eliud said earlier, that's scalable and reliable. So it's yeah, kind of a multi-pronged, multifaceted way forward. It's one part continuing to do what we're doing a little bit better and a little bit more broadly. I think changing our lexicon a little bit and moving beyond of kind of a very specific TB lens, and continuing to reach across the aisle with other partners, and doing everything that we can to support national governments have plans and policies and protocols that are able to support the most vulnerable. And those are just a couple thoughts from me, Sahu. Thank you.
Thank you, Michael. Reaching across the aisle, very aptly put, I think. So thank you, Michael. Eliud, you already said a few things about next steps. Would you like to add anything now?
Yep, sure.
Yes, go ahead.
Sure. First of all, I think I would like to echo what Michael just said. That first of all, I think the issue of nutrition as it relates to tuberculosis, and of course with other disease, is really is not yet discussed well, and it's really tackled on the margins. We need to have more discussion. We need to bring this to the core of TB prevention and treatment. So that is number one. Number two, I think we should not approach this in silo. We really need to approach it as part of the social program and social protection. It should be approached in an integrated way. I think we cannot get a traction if this is approached purely from the TB angle. So this is the other issue. We need to look at how we frame it from the TB point of view, and be able to speak with the language of other people, of social protection people, in an integrated way. And I think from us as a global fund, I think we need to look at also the issue of sustainability, the issue of operationalization of these programs, because this has been one of the challenge. But I think so far, what I've seen from the funding request, it has been approached as a way to improve TB treatment outcomes. But I think it's far bigger and beyond TB treatment outcome. It's a prevention issue. And I think we need to frame it that way. We need to approach it that way and look at it also as a package of comprehensive TB package, also for prevention and also quality of care. So from the Global Fund side, I think there are 2-3 important developments next year and in 2023. First, we'll be working on our replenishment from next year. We'll be working on the tools for the next funding cycle. And we need really to see how do we also frame this in all those tools which will be distributed from the Global Fund, ranging from the information note, funding request, modular framework, etc. So that will be an important part of that. But also we are working on operationalization of our next strategy. And there are some statements with regard to this area, but we really need to unpack that and see what it means for countries, for our funding, and for our programming. So those will be the follow-up steps from our side. Thanks.
Thank you, Eliud. So we have gone through all the panels, at least on the next steps. We had kept some time for question and answer, but it will be very brief. But I see a lot of questions on the chat, and some questions are already getting addressed. So we also have Minister Hajime Inouye there. Sir, you have raised your hand. Would you like to speak now, or should we do it in 5 minutes' time? We can't hear you. We can't hear you, Minister.
Hello, as an audience, hello, can you hear me?
Yes, go ahead.
not as the comments, but as an audience, I'd like to have a few technical questions if time permits.
Please go ahead. Please go ahead, sir.
Thank you very much. As the subtitle of this side event reads, undernutrition causes 20% of world's TB cases. This is true, and this figure 20% should be recognized. But at the same time, these side events are actually discussing the both sides, one undernutrition, the other overnutrition and TB. And I'm quite interested in the figure on the other side, 20% caused by undernutrition. And is there any quantitative analysis for the other sides, overnutrition and TB? Thank you. Over to you.
Thank you. That's a very good question. And yes, there are some quantitative assessment on diabetes side, if you take that as the over side of nutrition. If you add them together, actually, you are making a good point that it is a much bigger figure than 20% that nutrition has. And I must also say that in countries, this varies quite a bit. In some countries, it could go up much higher than 20%. And in some countries, of course, is less. But I would request anybody from the panel to respond to that question of the rest of the nutrition, what percentage it contributes to TB.
So can I respond?
Go ahead.
Dr. Sahu?
Go ahead.
So the Global TB Report 2020 had these figures in exact numbers. So apparently out of the 10 million cases of TB, they had attributed 2.2 million cases to undernutrition. And the combined proportion due to diabetes, HIV, and alcohol use disorder was actually coming out less than that. So diabetes is only about 5 to 7% of global TB incidence, about, I think, 350,000 cases globally. Qualification regarding diabetes is now new data is coming in. If the diabetes is well controlled, then actually the risk of TB is less. And the other confounding variable is that people who are obese, who are actually somewhat protected against TB incidence also. So we know the figures for the other risk factors also, and there that is where actually undernutrition is leading the risk factors in TB incidence. And as Dr. Saud said, the figure may be higher. We are also working on a manuscript which we have just submitted, where actually the proportion of TB cases attributed to undernutrition will be actually higher. There are some issues with the WHO estimations, which we will just point out, but maybe in a few months, this will be the subject of discussion. The risk ratio for TB is also probably higher than what the WHO has assumed. And the prevalence of undernourishment, which it is taking based on the FAO thing, is actually lower than the prevalence of low BMI that actually might be taken. So actually the figure will be 10 percentage points higher there.
Thank you, Anurag. So it is now open for questions. We will take one or two maybe, because we are running out of time. So I see a hand raised there, Redmi Note 8 Pro. Is that somebody who wants to speak? That was there for a long time. Anybody else would like to raise your hand? If you want to speak, please raise your hand so that we can identify you, and then you can go ahead and ask a question or a comment. I see Luchika there. Luchika, please go ahead.
Yes, and apologies that I raised my hand. I was actually planning not to, just to leave the other colleagues, but it's just, this is really, as somebody wrote in the notes, it's really very great educational, and we learn so much. There is so much to do. I want just to reemphasize something that was mentioned, and this is that, you see, when we plan for a TB response, it has to be a comprehensive package. And due to the poverty, let's say it this way, due to the lack of financing in TB chronically, traditionally, I used to work, as you know, in a program. I used to work then with several other very close. before I came here, went to, let's say in Geneva, I'm a bit more disconnected. But unfortunately, I see that the tradition continues because being so underfunded, there is the tendency of the program responses for the leaders in there, the TB program managers, other people in the ministries to really budget things that are more likely to be funded or more likely for which to exist the fund, you know? So, you know, when you make a comprehensive package for all TB, for all people that are affected by TB, and we include all this nutrition, but not just that, but all the other, the budgets, the needed budgets will be very high. And I think there is also a fear that it will look too high, like a pie in the sky, and then nobody will fund that. So I know there was discussion around it. I know Eliud also touched upon it. You know, nobody will fund unless we speak about it. You know what I mean? So we should not be worried or afraid or ashamed that we, speaking on behalf of those that are sick, we should not refrain for constructing budgets that include everything that is needed for a person. And yes, the budgets will be crazy high, but you know, some countries did that, and that helped in increasing their budgets. You know, we know about the India starting a few years ago doing the budget of what it means to NTB, and the budgets becoming doubling of what was then available, and even beyond that, I think tripling as well. Indonesia recently tripled that existing budget, which of course is not yet where it should be, but is growing. So including this kind of interventions and expanding the cross collaboration will be extremely important. But if we don't speak, or if we don't have it there, like kind of in the face of the decision makers and raising it for them, we will never be able to fundraise enough. You know, we speak at global level about needs for the programs to end TB of 13, 14, even higher, 15 billions a year globally, right? And then we observe that several programs are actually foreseeing not even half of what should be. And that is not a criticism. I fully understand that. In my country still works like that now, because you know, you feel worried to say, oh, I need $300 million when you know that the government will give you 50. And you are like, how can I go ahead and say? I think without flagging and including and making robust budgets that address all these components and going ahead in the way that we were and we are still doing it, but I prioritizing just some parts of it because, you know, prevention is too much, or communities is too much, or nutrition is like, oh my God, these people with nutrition come on top of everything, you know, without putting all these things and discussing, of course, with the ones that are responsible for these areas of work as well as we try to do here, I think we will not be able to have a clear picture of what is needed. Will it be heartbreaking? Yes. Will it be upsetting? Yes. Will we have the money right away? No. But without flagging it and expressing it, there will be nobody from the Ministry of Finance saying, I think for the TB program, we need to think a little bit about the nutrition. Nobody. If there is anything, things will be more even hidden. So we need to raise up and say, listen, we are here in these jobs to speak for people with TB, to be cured of TB, and for us to end TB. We really need all these things in place. You are giving us a third of the money. Fine, you know, we will fight to get more, and we will try to do the best what we get with the third. But you, decision makers, you funders, be aware that 2/3 of the money is a gap. And don't expect me to reach the end of the TB with 1/3 of the money, because I cannot do it. So that's why I want to ask you all the money. So this is just because I think it's good to have this discussion and perspective. And I am really learning so much. I was writing almost half of a notebook just to see how behind I am on all the knowledge that you are sharing here. So thank you very much, Sarah.
Thank you, Luchika. So we have 2 hands up now. We have to be quick because Minister Inouye will speak after this. So Anurag, should we give Yakiko Yoshida the first one, and then you can also respond if there's a question there.
Sure.
Makiko, can you please go ahead?
Hi, thank you very much for giving me to raise some question. My question might be a bit too specific, but I was just wondering, because you explained to us the TB is really related to severe acute malnutrition. I would like to know your thoughts on using RUTF or RUSF for TB treatment with malnutrition, with a very severe acute malnutrition status. Thank you.
Thank you, Makiko. So Anurag, please go ahead.
Yeah, so I could not agree more with what Dr. Ritu said. And when it comes to budget, I must say that it is not something which is TB specific that we should ask for, but TB has a bidirectional relationship with, I would say, the health system and with the social protection programs. So I think much of the program, budgeting should not be considered as TB specific, but which will address the needs of other people. This thing, for example, some of the nutrition budget could go to TB HIV as well. So if we and I can say this much, that as she said, that we have not been asking for things. Now India has one of the largest supplementary nutrition programs in the world, which has a large public distribution system, but which lacks quality protein at the moment. We have midday meal program in which millions of children are fed a hot cooked meal every day. And we have an integrated child development service where take-home rations are also given to pregnant mothers and children below 3. So it is just that there is a platform there where we have, if we articulate the need for this specific programming, it will be taken up. And I'll just quote 2 instances. For example, the TB program struggled with setting up PCRs, for so many years for TB diagnosis. But in COVID times, it was when it was sensed that this is an emergency, it was upscaled in no time. Similarly, I'll just compare the national program budget of TB in India in the 1980s, which was $500,000 a year for 2 million people with TB in India, whereas the TB program in New York used $1 billion to treat that spike of a few thousand patients. So there has been a real lack of the recognition that these are the needs. So I think if we speak with a single voice and have a discussion with, as we said, reach out across the aisle. And lastly, I would say that when we talk of multi-sectoral frameworks, it all looks very complicated. But if the strategy is flexible, decentralized, talks to the stakeholders in the community, those are the places where actually solutions, integrated solutions, are very easy to find. So whatever it is done should be not top-down, one-size-fits-all, but community-based and decentralized with flexibility built into the structure. Thank you so much.
Thank you. This is a very good discussion, but as everything good comes to an end, we have to start to wind up. But before that, so we close the panel discussion here. But I request now His Excellency Minister Hajime Inouye, who is the Assistant Minister for Global Health and Welfare in Japan, to please speak to us for the concluding remarks.
Thank you very much. As a person participating from the host country of the Tokyo Nutrition for Growth Summit 2021, I really appreciate all the participants of this side events. This is a great learning process for everybody. And especially thanks for the STOP partnership, TB partnership, for convening this event in this timely timing, just one day before the opening of the summit meetings. Actually, there are 120 participants actually right now listening to these side events. I assume majority of them are within TB community. So all of us actually share the same idea with regards to what's the current situation, how is the linkage between TB and nutrition. And we also exchange the idea on what's the next step. This is a great side event, but I think this is not yet enough. This is not suffice. The important next step is actually connect our shared understanding and shared idea within TB community with the rest of the world, with the public, and also especially with political leaders. This is the reason, in my understanding, why Lucicare and Stop TB partnership carefully convened, selected this timing just one day before the summit meeting of the Nutrition for Growth on this event. And I think it's important for us to actually connect our discussion, the portal discussion, to the mainstream of the summit meeting in the coming 2 days. I, as a person from the host country and as a person staying in Tokyo, have a certain role to actually hold the discussion in the first 2 hours to the mainstream of the summit meeting. I'm very happy to do that work. Thank you very much.
Thank you, Minister Inoue, and thank you for your wise words there, for connecting to the rest of the world, and thank you also for committing to do part of that into the mainstream conference there. Before we conclude, just a few points that came out in the discussion. It will be difficult to summarize such a rich discussion, but just a few things that we would like to also take forward. Some of the things very clearly articulated are related to advocacy. We need to let the world know more about this. We need to know the nutrition stakeholders and others know about this connection between nutrition and TB. So a lot of work needs to be done in that direction, and some important opportunities are coming. The World TB Day next year, the UNHLM after that, the G20 leadership, also Indonesia and India. So there are some opportunities there. Number two, what I also noticed is a lot of people either presented or called for more evidence. And we heard from Teresa that more guidelines are coming. So that's another piece of work that we should keep following up, more evidence, more guidelines on nutrition and TB. Then third, we also heard a lot of things about how do we scale it up, doing some practical things about assessments and scaling up things to the full need there. So a lot of things need to be there, need to be done in that area of how do we scale up in programmatic mode to everybody that is in need of nutrition with TB. And very important there also to think about it that this is not a luxury, this is not an option, but nutrition is essential part of TB response. So how do we do this? Some thoughts, many thoughts came in this area, but I think something that that kind of winds across all of them is this idea of multi-sectoral, reaching across the aisle to other stakeholders, and not considering just TB as working in isolation here. So those things have to be worked on further. And very good to have some stakeholders also from the non-TB side in this meeting. Also, I see in the audience some people that we don't really meet in TB meetings. Now, two important things for two different communities, TB as well as nutrition. One is they have to come together. But besides that, I think there was a very clear message for TB community to take nutrition as part and parcel of the TB response, of a comprehensive response. So how do we do that? How do we plan that? How do we get it funded? We saw Eliud also in his comment about global fund possibilities there, the domestic financing and all that. So TB community needs to take nutrition as part of the TB response. Not just, and some comments also, not just on focused on people who already have TB. We need to improve their outcome through nutrition, but also to prevent, as Anurag said, take it as a vaccine. The second community, I think TB community, there were some messages on how to make them aware, but also how not, the current preoccupation of the community with maternal and child health and emergency situations across the world, how to go beyond that and also put TB on the table for discussion and action for the TB, for the nutrition community. I think a lot can be done in this area. So both communities need to work together. We heard some words like it's a crisis situation. Anurag was trying to say also that all this work needs to be done, but concurrently we need to act. We need to save lives. So that is very important that we don't do it in a sequential way, but do it concurrently. So a lot of action points here. So we from Stop TB Partnership will be fully committed to take this agenda forward in all the streams with partners and also in some areas that we have our strong points on advocacy. So thank you all for joining this meeting and contributing to the rich discussion. We have also saved the chat. I realize that many discussions and many questions and answers were also responded to in the chat. So thank you all for contributing to that. So with that, let us close this meeting. We are just on time. Luchika, do you want to say anything, any last minute?
No, we are above the time actually, so thank you.
Thank you all. Have a nice day or a nice evening, depending on where you are in the world. Thank you. Bye.
Bye-bye.